A 22-year-old man comes to your OPD with a 2-day history of high grade fever, severe continuous headache, photophobia, and nausea. And you start thinking that since it's a fever, headache, and photophobia could be due to CNS involvement and infection. So you start examining the patient, and you see that he has neck stiffness and altered sensorium. Uh, and a very particular sign that you think that you will elicit is the Kernigs and Brudzinskis. So when you think of these signs, you're thinking in the direction of bacterial meningitis, which we'll see what it is. So acute bacterial meningitis is a purulent infection with subarachnoid space involvement, or we can say the leptomeninges getting inflamed, is associated with inflammatory reaction that can possibly result to decreased consciousness, seizures, raised ICP, and stroke. So there are multiple bacteria and multiple geographic and age patterns that can be seen in like this Hartmann's meningitis, which is seen in the sub-Saharan Africa's meningitis belt, where the outbreaks can be linked to the dry climate and dust storms. So about meningitis, it's a disease that spreads mostly in hot and dry climates where poor ventilation and crowding is present because it requires a closed airborne contact for transmission. Now, meningitis often occurs from other bacteremias that have focus on other parts of the body, like in ear, sinuses, or skull fractures. Some common causative agents that one should know about is the H influenza type B and S, which used to be common in India but has reduced incidence because of the intensive vaccination and important other causes like pneumococcus pneumonia. Now, in Western countries, Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza are common, while zoonotic links like Streptococcus suis, which can be linked to pig exposure. Now, another important organism, the Listeria monocytogenes, stands out where the neonates of more than less than 1 year, 1 month of age, pregnant women, and immunocompromised generally, like diabetics and others with individuals of more than 60 years of age are the most affected ones. This is usually acquired by ingesting food which is contaminated by listeria. So most commonly the cold storage food or the ready to eat food or the cold meat is important causes like coleslaw salad or milk or soft cheeses which are not cooked at the time of consumption. Some common facts that one should know about is chronic meningococcemia, which is rare, will cause prolonged fever, rash, and joint pain, and is usually seen in older adults or post-plenectomy patients. Pneumococcal meningitis, which can be linked to pneumonia, can be seen in alcoholics, especially older adults and people with hyposplenism. So let's talk about the pathophysiology of this disease for a moment. Since the invasion of subarachnoid space by the meningeal pathogen, this pathogen will keep on dividing, and the lysis of these organisms will occur by the bactericidal antibiotics, which will release the cell wall components like endotoxins and teichoic acid that will lead to production of inflammatory cytokines. So what these cytokines do is a massive array of things that will lead to further injury and raised ICP leading to coma eventually. But one by one, it leads to production of inflammatory, excitatory amino acids and reactive oxygen nitrogen species, which lead to direct cell injury and death. Alterations in cerebral blood flow will result in an increased and decrease in blood flow having their own similar symptoms, where decreased blood flow will lead to ischemia, more death, and symptoms like stroke and seizures, which will further complicate, and increased blood flow which will directly raise the ICP leading to coma. Now, production of inflammatory cytokines does increase the adherence of leukocytes to cerebral capillary endothelial cells, apart from an altered blood-brain barrier permeability itself. So, both of these factors play an in and out role in increasing the leukocyte migration into the CSF, which degranulate and release cytotoxic metabolites, which will further lead to cerebral cytotoxic edema and stroke and seizures, as well as the increased permeability of blood vessels with the leakage of plasma and plasma proteins in the CSF will cause exudate formation and thus leading to obstruction of outflow and resorption of CSF and surround and infiltration of the cerebral vasculature, which will further complicate cerebral ischemia and can cause obstructive and communicating hydrocephalus with interstitial edema. A direct effect of altered blood-brain barrier permeability will be vasogenic edema, which can directly cause raised ICP and further causing coma. So, in short, let's see what mediators played an important role. The INF alpha and interleukin 1 beta, which cause the inflammation and increase blood-brain barrier permeability. Chemokines, which attract leukocytes to site, reactive oxygen species and reactive nitrogen species, which are nitric oxide and peroxynitrate, can cause neuronal injuries, and neutrophilic enzymes, which contribute to cytotoxic edema. So, thinking about the pathophysiology, we can already see that the common symptoms could be headache, fever, neck stiffness, and drowsiness, which are common with raised ICP and meningeal irritation. Severe coma, and in severe cases, coma and focal neurological signs could be seen. Important for to know that when meningococcal meningitis occurs, most of the cases will see at least two of the signs of fever, neck stiffness, altered consciousness, and rash. Rapid deterioration occurs because of sepsis and cerebral edema. So that brings us to the clinical signs that are seen of because of meningeal irritation. So an important one, which is also the hallmark, is the nuchal rigidity, which is the other term for neck stiffness, where on passive flexion of the neck, resistance is felt. Now, a Kernig sign, which is done in supine position, the patient will flex the hip and knee, and on attempting to extend the knee, pain occurs, which suggests that there's meningeal irritation. A very similar one, Brudzinski sign, where the neck is flexed while the patient is supine, which leads to involuntary flexion of the hip and knees as an attempt by the patient to reduce pain, which is again an indicator of meningeal irritation. Now, there are limitations to these tests because specificity and sensitivity of them are very unclear, as these signs may be absent in very young and elderly, immunocompromised individuals, severely obtunded patients. And false positives can also be seen in patients with cervical spine disease, like cervical spondylitis. Common complications like hearing impairment can occur if treatment is not done at time, and uh, the disease may progress to further complications like as implication of raised ICP leading to coma or stroke or ischemic attacks, brain abscess, and such. Now, complications of meningococcal sepsis one can keep in mind as meningitis, rash, which is morbilliform petechial-purpuric, shock, intravascular coagulation, renal failure, peripheral gangrene, arthritis, and pericarditis. So management. If a patient has come to you with meningitis and you've isolated it, then it becomes very important that you start prompt treatment with empirical antibiotics and corticosteroids like dexamethasone. Though corticosteroids have they're used in reducing the neurological complications and hearing loss, but it is usually elicited in countries with have low penicillin resistance, and unclear benefits of steroids in regions of high HIV prevalence and penicillin resistance is there. Empirical antibiotics are important to be memorized. So, let's see that these antibiotics are decided upon because of the common etiologies that can affect the patient. So, if it's a preterm infant or an infant who's less than 1 month old, ampicillin with cefotaxime should be used. Infants of 1 to 3 months, ampicillin with ceftazidime and ceftriaxone. Immunocompetent children who are more than 3 months and adults less than 55 years of age can be given cefotaxime, ceftriaxone, or cefopime with vancomycin. Adults who are more than 55 years of age and are alcoholics or any other debilitating illnesses is present, ampicillin with cefotaxime, ceftriaxone, or a cefopime with vancomycin can be given. Hospital-acquired meningitis or post-traumatic or post-neurosurgery meningitis, neutropenic patients or patients with impaired T-cell mediated immunity can be treated with ampicillin, ceftazidime, meropenem, and vancomycin. So once you have decided and started the patient on empirical antibiotic therapy, it should be followed with scans, preferably a CT or an MRI, and CSF analysis, which is done post lumbar puncture. So, typical findings of a bacterial meningitis in CSF are the opening pressure, which is more than 180 water, and increased the white cell count, which is predominantly neutrophilic. Red blood cells is usually absent if it's a non-traumatic tap. A glucose of less than 2.2 millimolars per liter, and the CSF to glucose serum glucose ratio of less than zero point 0.4. A protein which is higher, which is 0.45 gram per liter or 45 milligrams per deciliter. Gram stain is usually positive in more than 60% of the cases, and culture is usually positive in in 80% of the cases. PCR can be done for detection of the bacterial DNA. So once the culture reports and sensitivity reports are there, treatment should be started for the particular organism, where Neisseria meningitis, which is penicillin sensitive, should be treated with penicillin or ampicillin. Penicillin resistant should be treated with ceftriaxone or cefotaxime. Penicillin sensitive with penicillin G. Streptococcus pneumoniae, streptococcus penicillin intermediate sensitivity should be treated with ceftriaxone, cefotaxime, or cefopime. Penicillin resistant strep pneumonia should be treated with ceftriaxone with vancomycin. Now, gram negative bacilli, except Pseudomonas, should be treated with ceftriaxone or cefotaxime. But if it's Pseudomonas aeruginosa, it should be treated with ceftazidime and cefopime or meropenem. Staph species like MRSA should be treated with vancomycin, while if it's methicillin sensitive, it should be nefacillin. Listeria should be treated with ampicillin and gentamicin. Haemophilus influenza with ceftriaxone, cefotaxime. If beta lactam is positive, and if beta lactam is negative, should be treated with ampicillin. Streptococcus agalactaceae should be treated with penicillin G and ampicillin. Bacteroid fragilis with metronidazole, and Fusobacterium species with metronidazole. So, in the end, meningococcal disease specifics should be kept in mind because sepsis in these diseases can lead to a higher mortality as compared to meningitis alone. Thus, ICU care is needed as it can cause multi-organ failure, and an early intubation and ventilation may prevent ARDS. Poor prognosis indicators are hypertensive shock, rapidly spreading rash, hemorrhagic diastasis, multi-organ failure, and an age of more than 60 years. So, at the end of the discussion, one should remember the definition of bacterial meningitis, acute bacterial meningitis, which is purulent, and the implications of uncorrected pathologies as discussed. Then the signs and symptoms, the signs which are signs of meningeal irritation should be kept in mind. The Kernig's, Brudzinski, and Ducal rigidity. CSF analysis findings of bacterial meningitis should be kept in note. I'll be covering the analysis of fungal and viral in the other videos, but for bacterial meningitis, the findings are very important and classical. Then at the end, the management, especially the empirical treatment, should be kept in mind, and common management protocols should be followed. So this was it for this video, and keep on watching further videos for more information, and feel free to ask any doubts. Thanks for watching.